Hello, everyone. Welcome to the AORA block of the month. I'm Murali here, and I will be speaking in the next 10 to 15 minutes about the axillary approach to brachial plexus block. How do we do it with an ultrasound guidance? I would like to refer you to an earlier video done by my good friend Dr. Ritesh, which is about the ENS guided approach to axillary brachial plexus block, where he covers in detail the indications, the contraindications, a detailed description of how to do it with a peripheral nerve stimulator, and also the finer nuances of the anatomy. You can scan this QR code, which will take you to that video. And in addition to that video, you will find a lot more interesting educative videos on the platform from Academy of Regional Anesthesia. So just to have a recap about what the Sona anatomy is all about, let's have a look at the anatomical and the Sona anatomical key points of axillary brachial plexus block. So the axillary approach is named so because it's around the axillary artery where the terminal branches are arranged. So as you can see in this cadaveric specimen, the musculocutaneous nerve will be in the coracobrachialis muscle. This is the ultrasound appearance of the same. Then surrounding the axillary artery, we will find the median nerve, the ulnar nerve, and the radial nerve. So the same thing as you can see here in the ultrasound appearance. The key thing here in this block is to identify what we call as a conjoint tendon, which is a tendon formed between by the teres major and the latissimus dorsalis. If you look at the variation of where these nerves are, again, Ritesh has covered it in detail, but I'm just taking you through a recap here, that the musculocutaneous nerve is generally seen in the coracobrachialis muscle. The median nerve is in this yellow quadrant, which is 1 and 8, these two quadrants. The ulnar nerve generally is between the axillary artery and the axillary vein, sometimes even residing away from the vein to axillary vein. And the radial nerve is generally seen below the artery, above the conjoint tendon in the fascia. This is just again a schematic diagram of the same, where you can see that the conjoint tendon and fascia are attached to the humerus. The coracobrachialis muscle has a musculocutaneous nerve in it, and the three terminal nerves which are arranged around the axillary artery are median, the ulnar, and the radial. This is how the brachial plexus takes its course from the interscalene groove, coming to the supraclavicular, the infraclavicular area, and finally the axillary area, where you can see all the nerves, which are the branches of the cords arranged around the artery. Now coming to the infraclavicular approaches, the costoclavicular, the classical infraclavicular, and the axillary approach form the three main approaches of infraclavicular approaches, and axillary being the most distal of them. So how do I do it? Now we'll take a few minutes to see what is the importance of position for both the patient and the operator. The key things about ergonomics. Then one which I won't go into detail is ensuring that every patient has functional IV line, the required monitoring, sedation if required, and of course, access to the resuscitation drugs. A little bit about the choice of drug. And finally, is dual guidance necessary in this block? So coming to the axillary approach to brachial plexus, the position that is generally described and what many use is the elbow flexed to 90 degrees and the arm abducted to 90 degrees. The operator can either sit at the head end as you can see here, and achieve the same along the line of visual axis ergonomic approach, or they can sit on the side of the patient and have the ultrasound on the other side and have an across the line of visual axis approach. The main thing here is that this block is best performed in sitting and having the ultrasound at the eye level so that there is no strain on the neck. So these are a few points about the ergonomics of this block. Now coming to what are the key requirements for this block. Now this is a tray that I have arranged before we do the block. So we generally tend to use betadine as an aqueous medium. The probe is covered by this sterile glove, which is economically feasible, plus also keeps the probe cover intact. It is not like the adhesive covers that some centers or some practitioners use, which can damage the lining of the ultrasound probe. And of course, I have a few rubber bands here, which are again ETO sterilized, and local anesthetic for the skin infiltration and the local anesthetic for the block, along with echogenic needle. Now coming to the probe cover, as I mentioned earlier, this is how the probe would look after covering the probe with a sterile probe cover and the sterile rubber bands. This is the typical arrangement in an operating room where we have the operator sitting at the head end with the ergonomics in along the line of visual axis arrangement. And as you can see here, this is the way the needle is inserted perpendicular to the line of axis of the nerves and in an in-plane approach to the ultrasound probe. So when we enter, we will see that there is a coracobrachialis muscle here, which has got the musculocutaneous nerve inside it, the conjoint tendon, the axillary artery, a radial nerve, which looks like a grape-like appearance here, the ulnar nerve, which is at around 11 o'clock position here, and then, of course, the median nerve, not very well seen here. With the tilt of the probe, we could see it better, sitting at around 1 to 2 o'clock position to the axillary artery. Now, the important thing here is the musculocutaneous nerve is being approached with the needle in a tangential manner. We are not directly going towards the nerve with the needle. We are going a little bit in tangential manner. And as you can see here, the local anesthetic is spreading in the fascia, which covers the musculocutaneous nerve. 2 to 3 or maximum 5 ml is enough to cover the musculocutaneous nerve in the coracobrachialis muscle. Coming to the nerves, 3 different nerves that we are going to block. We have already blocked the radial nerve here. You can see the local anesthetic underneath the artery covering the radial nerve. The needle is now advanced with some hydrodissection to the other side of the artery covering the ulnar nerve. And you can see all the 3 nerves floating with local anesthetic now. So the radial nerve underneath the artery, the ulnar nerve here, and the medial nerve on top of the artery. And you can see, again, very important to note that the conjoint tendon is very well visible, because it's important to appreciate the conjoint tendon and its fascia, because the radial nerve will be sitting on top of it. This is again a different arrangement that we saw in another patient. As you can see, the musculocutaneous nerve is here. The radial, the ulnar, and the median are all clumped towards one side of the artery, and we can see the vein on the other side. One of the key things here in the axillary approach to brachial plexus is that we will miss the intercostobrachial nerve and the medial brachial cutaneous nerve. This paper highlighted the ultrasound anatomy of these nerves, and as you can appreciate here, with regards to the earlier sono anatomy video that I showed you, the musculocutaneous nerve, the median and the ulnar and radial nerve. And these nerves, which is the medial brachial cutaneous and the intercostal brachial nerves, are further away, probably a centimeter or two, but again, more importantly, resting on the conjoint tendon and fascia, that is the latissimus dorsi and the teres major. So if you were to extend your needle a little bit ahead when you're giving either the ulnar nerve block or the radial nerve block and infiltrate a few mils of local anesthetic into this subcutaneous tissue overlying the latissimus dorsi and the teres major conjoint fascia, the medial brachial cutaneous nerve and the intercostal brachial nerves can be blocked. This is the paper describing the sonoanatomy, again of the same, where we can see the medial brachial cutaneous and the intercostal brachial nerves. What is the minimum effective volume required? Traditionally, large volumes were used when either it was a landmark or a PNS guided technique, but with ultrasonographic guidance, the minimum effective local anesthetic volume can be decreased to as little as 2.5 to 3 ml per minute. So if we use this calculation of 2.5 ml for each nerve, we can actually do this block within 10 ml. But there are other papers which suggest that to have a comfortable duration of the block without the block wearing off early, roughly around 3 to 4 to 5 ml are required for each nerve, which might total up to around 15 ml for this block. The choice of drug again has been explained in detail by Dr. Ritesh in his video, but I would like to reiterate here that bupivacaine 0.5% can provide adequate anesthesia and analgesia when axillary approach to brachial plexus is used. Is it safe is another question which is arising now, with newer papers suggesting that the block failure, the neurological dysfunction, and even the rate of infection might be same or more than the other approaches to brachial plexus, such as highlighted in this article, which showed that the axillary approach has got close to 17% block failure, 10% of neurological dysfunction, and up to 4% of infection. The only other block which had higher rate of infection was infraclavicular when catheters were used, but otherwise, axillary approach had highest block failure and neurological dysfunction. So it's very important to note that even if it's a superficial block where the nerves are seen, it's highly important to be careful when we are doing the block and ensure that there is good amount of local anesthetic spreading around the nerves. This was another article from Japan which highlighted again that the axillary approach can have a higher incidence of neuropathies. So the recent few years have shown that axillary brachial plexus block might not be as safe as we thought it could be. So we need to be more careful when we do these blocks. Just in comparison for the infraclavicular approaches that we have, we can see that axillary scores well when it comes to target depth, the needle angle being quite flat, so you can see the needle very well. The disadvantage being that we need to have multiple passes to cover all these nerves. Proximity to pleura is not an issue here. It is definitely compressible, so can be given in patients on anticoagulants and deranged coagulation parameters. The need for arm abduction is very much required here when compared to, say, the infraclavicular. So patients with trauma who cannot abduct the hand can find it difficult to receive axillary brachial plexus block. The nerves are seen and the volume is definitely lesser than the nerve. So there are a few good things about the axillary block, but as I highlighted, the recent data is showing that we need to be careful when we are doing these blocks. So just to end my brief talk about this, a few clinical pearls. Apply very minimal pressure with the transducer because the veins can get compressed. And if you are in the vein and injecting something like bupivacaine, the local anesthetic, systemic toxicity can be a big issue. So apply minimal pressure. Use a bouncing kind of technique where you apply pressure and release it so you can see all the veins and stay away from them. Apply a color Doppler whenever you're in doubt, whether you want to understand whether this is a vessel that you're talking about. So ensure that you apply color Doppler before you do the block. Deposit the local anesthetic posterior to the artery first to cover the radial nerve. Because if you were to do the injection on top for the median or the ulnar, it can depress the artery, it can obscure the structures underneath, and therefore doing the radial nerve block later might be an issue. Hydrodissection is a very important thing in axillary block because you need to understand to slowly dissect the fascia and identify the neural structures. So hydrodissection is extremely important. If you cannot see the nerves, it could be a patient who is obese, patient with difficult anatomy, trace the nerves from distally back to axillary. So it can be from the elbow. We can trace the median nerve, which always accompanies the brachial artery up to the axillary artery. We can trace the ulnar nerve from the medial aspect of the humerus to the axilla. We can trace the radial nerve from the radial groove up into the axilla. So trace the nerves distally back to axilla. Even if you're in doubt at this point, surround the artery with local anesthetic. This tends to work most of the times if you're in doubt because the nerves are arranged around the artery. And definitely think about using an electrical nerve locator, also called the PNS colloquially, to identify the nerves whenever in doubt. So just with these tips, I would like to end this very brief and short description of how to go about doing an axillary approach to brachial plexus block using ultrasound. Thank you very much.